Afternoon, everyone. I'm Malika Ashford. I'm an editor at GenomeWeb, and I'll be your moderator today. The title of today's webinar is Current Trends in H. pylori Testing, Disease State and Diagnostic Modalities, and this event is sponsored by Meridian Biosciences. Our speaker today is Dr. Aamir Ali, a gastroenterologist at Capital Digestive Care. You may type in a question at any time during the webinar. You can do this through the Q&A panel, which appears on the right side of the webinar presentation. If you look to the bottom tray of your window, there are a series of widgets to enhance your webinar experience. With that, I'll turn it over to Dr. Ali.
Thank you for the introduction, Malika. Good afternoon, everyone, and thank you for joining us this afternoon for a discussion on H. pylori. We'll start the talk with an overview of H. pylori infection. We will discuss the indications for testing. We will review the GI Society guidelines regarding when it is appropriate to test for H. pylori and what the best modalities for testing might be. And we will end with a discussion of the various testing modalities that are available for the diagnosis of H. pylori. These modalities, as you might know, are broadly divided into invasive and non-invasive testing modalities, and we will discuss the major modalities available in each of those categories. So let's first start with the question, what is H. pylori and why is it important? H. pylori is a gram-negative flagellated rod-shaped bacteria that dwells in the lining of the stomach. It is the most common chronic infection globally, and it's also the most common chronic infection in the United States, where about a third of the population is infected at any given time. H. pylori can survive for prolonged periods in the lining of the stomach, where it can cause chronic inflammation. As a result of this chronic inflammation, a host of disease states can emerge. And these can range from peptic ulcer disease, which includes gastric ulcers and duodenal ulcers, and for which in about 80% of cases, H. pylori is the cause, ranging all the way up to various types of cancers. Chronic inflammation can be a cause of cancer. It can lead to malignant transformation, and gastric adenocarcinoma has been found to be associated with H. pylori infection, as has malt lymphoma. As a result of these associations, the World Health Organization has named H. pylori as a class 1 carcinogen. Class 1 carcinogens are substances that are known to cause cancer, and known as opposed to presumed or suspected. Other substances that fall in this category are ultraviolet light, tobacco, and asbestos. So it's in a pretty rarefied category of agents that have a firmly established relationship with cancer. There was an article in 2012 in the journal Lancet, which said that H. pylori is one of the 6 common infections that leads to cancer, and that early detection and treatment of H. pylori can result in the prevention of cancer. And again, the other infectious agents that were in this category were human papillomavirus, HIV, hepatitis B, hepatitis C, and Epstein-Barr virus. So again, it's in a group of agents that have a very firm and established relationship with cancer. H. pylori and its various associated conditions result in nearly $10 billion in healthcare costs. Now, these numbers are old, so if we look at, if we were to calculate these numbers closer to today, that number would be significantly higher. As mentioned previously, H. pylori is the most common chronic infection around the world, but its prevalence is not evenly distributed across the world. Whereas the global prevalence is about 44%, its prevalence is much higher in developing countries, where it exceeds 50%. The prevalence in developed countries is more similar to what we see in the United States, in the neighborhood of about 30%. And the reason for this disparity among developing and developed nations has to do with the mode of transmission. H. pylori is transmitted primarily by the fecal-oral route and also by the oral-oral route. And this mode of transmission makes the disease much more easy to propagate when sanitation is poor and when there is a lot of crowding, utensils are shared, etc. For this reason, we see on a global scale a predominance of disease or a predilection of disease towards less developed countries. And when we look at countries themselves, there is a gradation across socioeconomic strata, with the disease tending to be more concentrated in the lower socioeconomic strata. There is a slight male predominance. There are various theories that are posited for this. The one that seems to be most accepted is that women tend to receive antibiotics more commonly than men, and that may lead to unintended eradication of H. pylori infection in women to a greater degree than men, and that may account for this slight difference that we see. It's not so much that men are being infected more, it's more that there may be a slightly higher use of antibiotics, or actually there is a higher use of antibiotics among women. Within the United States, the prevalence of H. pylori is about 30%. And once again, it's not evenly distributed. It ranges from about 20% prevalence in the white population to 54% in the African American population, 60% in the Hispanic population, all the way up to 74% in the Alaskan Native population. There's also an age cohort. Individuals who are in an older cohort tend to be more likely to be infected, and this really has to do with the fact that most infection occurs in childhood, and older cohorts are more likely to have spent their childhoods at a time when sanitation was not as good as it would be in subsequent years. And we do see that in the distribution of disease in the United States. Demographically, individuals who are younger than 30 years have a prevalence of H. pylori of around 20%. Individuals older than 60 years have a prevalence of over 50%. So again, that cohort effect is quite apparent when we look at the distribution of disease in the US. H. pylori, as we discussed, can cause a chronic inflammatory state, and various disease states can emerge from this chronic state of inflammation. There is a known association and indeed causal association between H. pylori infection and gastric adenocarcinoma. We know that individuals who have H. pylori infection have a 6-fold higher lifetime risk of developing gastric cancer. And we also notice that gastric adenocarcinoma tends to be endemic to regions where H. pylori infection is very high. And as H. pylori infection decreases across societies, we see a parallel decrease in the rates of gastric adenocarcinoma. The other cancer that is associated with H. pylori is mucosa-associated lymphoid tissue, or MALT lymphoma. Peptic ulcer disease, which includes both gastric ulcers and duodenal ulcers, is caused in up to 80% of cases by H. pylori. Functional dyspepsia is a term that is used to describe individuals who have upper abdominal pain in the absence of ulcer disease. And this is quite common, and individuals with this condition may have H. pylori as a cause of their symptoms. Many instances of iron deficiency anemia can be related to H. pylori infection, and many cases of idiopathic thrombocytopenic purpura, which is a disease state in which low platelet counts can lead to clotting, is also associated with H. pylori. This is a schematic that provides a basic overview of the pathogenesis of H. pylori. Normally, epithelial cells of the stomach, which are the cells that line the stomach, are protected from stomach acid by a mucus layer. H. pylori bacteria have various adaptations that allow them to burrow into the mucus layer and get right up next to the epithelial cells. We mentioned earlier that the bacteria is flagellated, so the flagella can help the bacteria burrow into the mucus layer. Its spiral shape also helps it sort of corkscrew into the mucus layer and get next to the epithelial cells. One of the hallmarks of H. pylori bacteria is that it produces the enzyme urease. Urease catalyzes the reaction of the conversion of urea to carbon dioxide and ammonia. When ammonia is produced as a result of the activity of urease, ammonia is an alkaline substance and it reduces the acidity in the immediate environment of H. pylori bacteria. So once they get next to the epithelial cells, H. pylori bacteria are able to survive by making the environment around them less inhospitable to themselves, by catalyzing the conversion of urea to ammonia and creating a less acidic microenvironment. So the bacteria thrive in that environment, and through the action of cytotoxins and through the action of virulence factors, they result in cell damage or cell death, which in turn results in a state of chronic inflammation. And it is as a consequence of this chronic inflammation that the various disease states that are associated with H. pylori tend to emerge. The American College of Gastroenterology has issued various guidelines around H. pylori, and one of the guidelines addresses indications for testing. We have the ability to test for H. pylori, but who would be the ideal candidate? Who are the individuals that we should target for testing? Individuals who have peptic ulcer disease or who have had peptic ulcer disease in the past should be tested for H. pylori, because eradication of H. pylori for those who have ulcer disease helps expedite the healing of the ulcers. And those who have a prior history of ulcer disease, treating H. pylori infection reduces the recurrence of ulcer disease. Malt lymphoma, as we know, has been found to be associated with H. pylori, and the association is causal. Very early stages of malt lymphoma can be simply treated with eradication of H. pylori. So very early cases of malt lymphoma can actually regress after treatment of H. pylori infection. We also have discussed previously the relationship between H. pylori and gastric adenocarcinoma. When gastric adenocarcinoma is found early and is resected, eradication of H. pylori reduces the likelihood of recurrence of gastric adenocarcinoma in those instances. So another indication of testing is after the diagnosis of gastric cancer to make sure that it does not recur after resection. Dyspepsia is abdominal pain, which is concentrated in the upper portion of the abdomen. It affects 20% of the US population, and because of how common it is, the majority of H. pylori testing that occurs tends to be in individuals with dyspepsia. So that group of individuals are ideal for testing for H. pylori. Individuals with unexplained iron deficiency anemia should also undergo H. pylori testing, as should individuals who have ITP. Now, we know H. pylori is an independent risk factor for peptic ulcer disease. Aspirin and nonsteroidal anti-inflammatory drugs are additional independent risk factors for peptic ulcer disease. When both risk factors are present in the same individual, the risk is increased synergistically. So it is important for individuals who are about to start low-dose aspirin, for instance, when people develop heart disease or they have risk factors for heart disease or stroke, and they need to be started on low-dose aspirin, those individuals, if they have underlying H. pylori infection, could potentially end up with two independent risk factors for ulcer disease that can synergistically increase the risk of ulcers. So for this reason, it's important to evaluate for and to eliminate one of those risk factors to reduce the long-term risk of ulcer disease. For this reason, the American College of Gastroenterology guidelines And other guidelines, like the Maastricht guidelines from Europe, support looking for H. pylori in individuals who are about to start long-term treatment with low-dose aspirin. Similarly, individuals with rheumatologic conditions may require long-term use of medications like Advil, Motrin, Aleve, or ibuprofen, or the non-steroidal anti-inflammatory drugs. And again, as these medications themselves are an independent risk factor for ulcer disease, we want to eliminate H. pylori as a second potentially synergistic risk factor. So for these individuals who are about to embark on long-term NSAID treatment or are currently on NSAIDs should be strongly considered for H. pylori testing. Given how common dyspepsia is, I think it warrants its own discussion. As mentioned, the definition of dyspepsia is abdominal discomfort that is centered around the upper abdomen. It can be associated with other symptoms such as belching, bloating, nausea. It affects about 20% of the population within the United States. The expenses associated with dyspepsia are huge. It's one of the most common reasons individuals seek medical attention. It's one of the most common diagnoses that bring patients to their primary care physicians, to urgent care, or to the emergency room. The estimated costs of dyspepsia are about $18 billion in direct costs. It's important to note that this is likely an underestimate because most people with dyspepsia end up not coming to their providers, and they tend to self-diagnose and self-treat with over-the-counter medications. So if we were to add all of those things, if we were to add the cost of absenteeism from work, that cost would be much, much higher. The American College of Gastroenterology has issued guidelines around the management of dyspepsia. And for most people with dyspepsia, they recommend that a non-invasive test of active infection be the first workup or the first test that's performed to work up that symptom. Now, the individuals who should get H. pylori as the first-line test for the management of dyspepsia are individuals who are younger than age 60 and who do not have alarm signs. Alarm signs are signs that raise concern for possible concurrent cancer. So alarm signs are anemia, weight loss, vomiting, a family history of gastrointestinal cancer. So if these risk factors are present, then endoscopy should be pursued. Similarly, if symptoms occur in individuals who are older than age 60, endoscopy should be pursued. But if you look at people who are evaluated for dyspepsia, the overwhelming majority tend to be individuals who are younger than age 60 and who do not have alarm signs. So for most people with dyspepsia, the test of choice, the first test would be a non-invasive test of active infection. The paradigm for the management of H. pylori infection can be summarized as test, treat, and retest. For individuals who have indications for H. pylori testing, testing should be performed to identify the bacteria or to identify the infection. And once the infection is identified, it should be treated. It does not matter if the person is asymptomatic when the diagnosis is made, because the bacteria is a carcinogen, treatment should be offered. And when treatment is completed, patients should be retested to confirm eradication. And what is the reason for retesting? It owes primarily to increased antibiotic resistance. Several decades ago in the 1980s, when the first H. pylori treatment regimens rolled out, the response rates were in the range of 85%. Now, what has happened over the decades is that the use of antibiotics has increased, and we have started to see antibiotic resistance to some of the common agents used for the treatment of H. pylori. There are some communities in the United States where the eradication rates with the standard regimens can be as low as 60 or 70%. Because we tend not to know what the local rates of antibiotic resistance are, it's important to make sure that after treatment has been completed, the patient does not remain infected uh, with H. pylori. For this reason, after completion of treatment, all individuals who have been treated should undergo a second round of testing to confirm that the bacteria has indeed been eradicated. If it has not, those individuals still remain at risk for the disease states associated with H. pylori. For this reason, it would be important to target those individuals for retreatment, perhaps with a different set of antibiotics. Now let's go over the various testing modalities that are available to evaluate for H. pylori infection. Broadly, these modalities can be divided into the invasive tests and the non-invasive tests. Invasive tests are tests that require a biopsy specimen in order to be performed. The biopsy specimen is typically obtained during an upper endoscopy. There are two common invasive tests. The first is histology, and the second is rapid urease test. And we'll talk about each of these tests individually in subsequent slides. Non-invasive tests rely on specimens that can be obtained without a biopsy. These specimens can include breath samples, stool samples, or blood samples. The three most common non-invasive tests for H. pylori are the urea breath test, the H. pylori stool antigen test, and H. pylori serology. So the invasive tests consist of histology. Histology involves examination under the microscope of tissue obtained from the gastric lining during biopsies taken as part of upper endoscopy. The bacteria are identified directly under the microscope, and diagnosis is made definitively on that basis. The strengths of histology testing is that it is a very sensitive and specific test, but even this test suffers from various limitations. It is invasive. You do need to perform an upper endoscopy to obtain the biopsy specimen. It is expensive. Of all of these tests, it is the most expensive. And the sensitivity of histology decreases when patients are taking acid suppressive medications, specifically the proton pump inhibitors. When histology is performed in individuals on proton pump inhibitors, the sensitivity and accuracy are less than optimum. Rapid urease test employs a medium that contains urea as a reagent. Biopsy specimens are added to this medium, and if there is H. pylori within these biopsy specimens, the urease that is present or produced by H. pylori converts the urea to ammonia and carbon dioxide. The ammonia changes the pH of the medium to an alkaline pH, and the change of the medium to the basic or alkaline range results in a color change that alerts the clinician to the presence of H. pylori. This test is typically performed at the bedside when an upper endoscopy is being performed. The specimen is removed from the biopsy forceps and placed into the medium. And usually when the patient is ready to go home, the result is available. And if H. pylori infection has been identified, treatment can be prescribed right then at that setting. So that is a major benefit of this procedure, and it's also quite inexpensive. The limitations of the procedure are similar to histology, that sensitivity tends to suffer when patients are on acid-reducing medications such as proton pump inhibitors, and also when the sampling is done at a time when the patient is having gastrointestinal bleeding, the ambient bleeding can reduce the sensitivity of the test. In addition, because this is a test that the clinician basically handles the specimen, performs the test, and reports the results, it tends to suffer from from kind of operational issues. Sometimes the clinician will see a positive result, may tell the patient, but may not put it on the chart. So there are no formal reports issued. And so that can result in a lot of results being lost or not being documented as they ought to be. Similarly, the chain of possession of the specimen is not well documented. Usually the clinician will take out the specimen and will perform the test. In endoscopy labs where I've worked in the past where this test was used, you would see specimens lying around without labels. And so, there's kind of this issue where you can essentially get loss of specimens or mislabeling or misattribution of specimens. So there's a little bit, because of the setting where it's done, it's dependent on the facility and how robust their operations are surrounding this form of testing. Now, going on to the non-invasive tests, let's first discuss the urea breath test. This test leverages the production of urease by H. pylori bacteria. In order to do the test, the patient drinks a reagent that consists of urea, and this is urea made with isotopes of labeled carbon. And when the patient drinks the medium, if they are H. pylori infected, the urease in H. pylori converts the urea to carbon dioxide. And this carbon dioxide is exhaled through the lungs and collected in breath samples because the carbon dioxide now contains isotopic carbon, you can measure how much carbon is being released, how much labeled carbon is being released. Now, this test has a very high sensitivity of over 95%, and it has a specificity of 93%. The strengths of breath testing are that it's highly sensitive and specific. It is non-invasive. It is a test of active infection. It can only be positive if active H. pylori bacteria are present, if urease is present. So it tells you, if it's positive, that you actually have living bacteria. There was a meta-analysis of multiple studies of urea breath testing and stool antigen testing, which found that breath testing is actually more accurate than stool antigen testing. The test is easy to administer, and it can be performed in a variety of settings. It is common to see urea breath tests being performed in primary care physician offices, in gastroenterology clinics, in urgent care centers, and in the emergency room. In fact, during the pandemic, the lab that's associated with the practice where I work sent breath testing kits to patients' homes because patients were reluctant to come out and do breath testing, and some employees were reluctant to have patients breathe into the specimen bags at a time when there was concern of spreading infection. So we actually mailed out the kits to patients, and the patients preferred performing the test in that setting to coming to the office. And now that those restrictions are no longer in place, there are many patients who voice a preference to having a kit sent to their home or to picking up a kit and taking it home and doing the test at home. So there's precedence to the test being performed with a high degree of accuracy in patients' homes. And the other benefit of urea breath testing is the sample type. Stool antigen testing requires the handling of stool, which some patients find unpleasant. In a study that looked at patient preferences, it was found that about twice as many patients would prefer to do or to deal with a breath sample as compared to a stool sample. Now, urea breath test also has some limitations. Like many of the other modalities, the sensitivity of urea breath testing tends to decrease in individuals who are taking a proton pump inhibitor. For this reason, it is recommended that H. pylori testing be performed 7 to 14 days after stopping or holding a proton pump inhibitor. The other limitation is that current or recent use of antibiotics can reduce the sensitivity of urea breath testing. For this reason, individuals should complete any course of antibiotics that they might be on 2 to 4 weeks before H. pylori testing is performed. And the second non-invasive test is the stool antigen test. This is a test that detects H. pylori antigens in stool specimens. This test initially was a polyclonal antibody-based EIA. While it performed well for the initial diagnosis of H. pylori, it was found that when polyclonal tests were used to confirm eradication after antibiotic treatment, the accuracy was not as high. This led to a migration of a lot of these tests to using monoclonal antibodies. And once monoclonal antibodies were used, the accuracy increased and it became a test that was quite accurate and could also be used to confirm eradication after testing. Now, all of the commercially available tests in the United States are monoclonal tests. They have high sensitivity and specificity of 94 and 97% respectively. The strength of stool antigen testing is that it is highly sensitive and specific. It is, like urea breath test, a test of active infection. It is positive when actual bacteria is present. It is, like the urea breath test, endorsed by guidelines from the American College of Gastroenterology and other gastroenterology professional societies. It is inexpensive. It is easy to produce and deliver the sample to the lab, and the sample may be collected at home. Some of the shortcomings of stool antigen testing are that it tends to have decreased sensitivity when proton pump inhibitors are being used by the patient. It also suffers from decreased testing when the patient is on antibiotics. For this reason, proton pump inhibitors should be stopped 7 to 14 days before stool antigen testing, and any course of antibiotics should be completed within 2 to 4 weeks of stool antigen testing. As mentioned previously, some patients may find the handling the stool specimen to be unpleasant. And it's important to elicit patient preference because a lot of patient adherence has to do with patient tolerance and preference. So given that there's a range of options for testing, it's important to also see which is more acceptable to the patient. And the third of the non-invasive tests is serology. This is an ELISA that's lab-based, and it detects IgG antibodies directed at H. pylori. Now, an important distinction to make is that serology is not a test of active infection. And this owes to the fact that we are measuring antibodies to H. pylori. We're not directly looking at H. pylori and its presence in the specimen. Now, as we know, antibodies can be present for a long time after the infection is gone. They can persist for months, and in the case of H. pylori, even years after the eradication of the underlying infection. For this reason, all a positive H. pylori serology tells us is that that individual has been exposed to H. pylori at some time in the past. It does not tell us whether that infection is still present. And this results in some of the inaccuracy that is associated with serology. The sensitivity of H. pylori is lower, in the range of about 85%, and the specificity is lower still, around 75%. The more telling parameter for serology as far as its inaccuracy is the positive predictive value. Positive predictive value is determined by the prevalence of whatever condition is being tested for in the population that is being tested. Where the prevalence of the condition is low, the positive predictive value is low. If the prevalence is high, the positive predictive predictive value is higher. Now, there are many communities in the United States where the prevalence of H. pylori is about 20%. So in those communities, the positive predictive value would be in the range of 50%. And this is significant because if you get a positive result on serologic testing in individuals from this population, there is a 50% chance that the test is a false positive. And this has significant implications on the appropriateness of H. pylori treatment and antibiotic stewardship. So if we are treating individuals based on a positive serology in low prevalence populations, we are treating as many people who do not have the infection as we are treating individuals who have the infection. And about half the people that we're treating did not need the treatment. So there's inappropriate use of antibiotics, the costs associated with that, increased resistance that is associated with inappropriate antibiotic use, and the increase in iatrogenic or nosocomial infections like C. difficile. So the limitations of serology then are that the sensitivity is lower than the alternatives, as is the specificity. The more telling metric, however, is the positive predictive value. And across much of the United States, serology has a low enough positive predictive value that it's no more accurate than a coin toss. And that phrase was used by the American College of Gastroenterology guideline in 2007. There's significant variability in accuracy in the commercially available kits. And this points to a need for local validation. If a commercially available kit was developed in a different geography than where it is used, there's enough difference in strains where the sensitivity in an area separate from where validation occurred would be significantly less. Test kits developed in Europe have low accuracy in Asia and vice versa. And actually, even within the United States, if validation was performed in certain populations, the performance characteristics will be different when the test is utilized in a different population. Now, it is impractical to perform validation in every locality where serology is offered, and it really is not done. So one of the conditions to offering serologic testing is really not met in the real world. And for this reason, its use cannot really be deemed appropriate. For this reason, current guidelines do not recommend serologic testing for the routine diagnosis of H. pylori infection. So in summary, H. pylori is the most common chronic infection globally and in the United States. It is named as a Class 1 carcinogen by the World Health Organization. Accurate diagnosis of H. pylori is critical to prevent the disease states that are associated with H. pylori, some of which include malignant disease states. So accurate detection of H. pylori and appropriate treatment can actually result in reducing gastric cancer and malt lymphoma. A variety of tests are available, but the tests that are ideal for testing and the most accurate are the non-invasive tests of active infection. We should pay attention to patient preference and patient characteristics to determine what the appropriate test might be in each individual patient. Urea breath test and stool antigen testing are both supported by the current American College of Gastroenterology and other guidelines for both the initial diagnosis of H. pylori and for confirmation of eradication. Serology is not a test of active infection. It merely tells us that the individual at some point has been exposed to H. pylori. It suffers from poorer performance characteristics. The most notable performance characteristic is the low positive predictive value in low prevalence populations, and for this reason, its routine use is not supported by the current guidelines. So Thank you for all of your attention during this talk. And now we'll open it up for questions. Please type in your questions and we can answer them in turn.
Yes, thank you so much. As a reminder to webinar participants, if you have a question, please type it into the Q&A box in the control panel. We'd also like to ask attendees to take a moment after the webinar has ended to take our exit survey and give us your feedback. Let's begin. The first question is, of the testing methods, the non-invasive testing methods, stool-based or breath, how do you make that decision about which one to use in patients?
That's a good question. And I think it's important to have a variety of tests because I think there are, issues of availability, issues of patient preference, which can guide which of those tests you might use. Many of the clinics have breath testing available, so you can basically test the patient while they are there, so they don't have to go to a lab. So if it's easily available, you perform that test. And I also think it's important to ask the patient because we've shown time and again that patient tolerability of tests and treatments are predictive of adherence. So if you mention the available modalities and the patient has an aversion to doing a stool test, then they're more likely to perform and actually complete the breath test. If they feel, that the breath test may be complicated, then they would state their preference for the stool test. So I think the important thing, because between the urea breath test and stool antigen test, the performance characteristics are similar. It really comes down to patient preference and availability within your practice environment.
Okay. In those cases where tests are confounded by PPIs, what is the recommendation for patients that can't tolerate stopping those drugs? Do they still get tested?
That's a good question. And there are some patients who just cannot or will not come off of their acid-reducing medications. There are a couple of ways that you can address that. One is the sensitivity is not as affected by the H2 receptor antagonists like Pepcid or I guess when Zantac was available. So you could transition them to those medications so they still have something on board that controls their symptoms and have them be on those medications for a week to 2 weeks and then do either the urea breath test or the stool antigen test. So that's one method of doing it. The other is that you can perform the test on treatment. And in that scenario, a positive result, because it reduces sensitivity. So the risk is that it might miss infection if it is there. So if you end up getting a positive result, it's a true positive. But if you end up with a negative result, the caveat is that because of the reduced sensitivity, given that the test was performed on proton pump inhibitors, the negative may be a false negative. So in that scenario, for the group of patients who get a positive result, they're off the hook. You can treat them for H. pylori, you have your answer. But for the group of patients who test negative, then you kind of have to have the conversation about, would you be willing to either stop the medication or transition to, to an H2 receptor antagonist? I will say that now that a lot of negative press has come out about proton pump inhibitors, people don't resist stopping them as much, because they kind of have this motivation to find out if something else is going on. Because if it's H. pylori infection, that may help them come off of the PPI. Given some of the possible long-term complications of PPI, they would prefer to know that. So I think I find people less resistant to stopping the acid-reducing medications now than even 5 years ago.
Sure. For the urea testing, can that be confounded by other bacterial infections like gastroenteritis or things like that? Or is it really limited to the impacts that you listed?
I think the characteristic of the bacteria that is leveraged to, as the basis of the urease breath test is pretty uncommon among other bacteria. There are not that many bacteria that produce urease. There are not that many bacteria in the gut that produce urease. So for that reason, it would be difficult for other flora in the gut to mimic H. pylori. So the likelihood is very low.
Going a little more broad, is testing traditionally reimbursed in all the indications that you cited, or does that depend on the test modality?
One of the things that has happened recently, not recently, it's been happening for the past decade, is many of the major carriers don't reimburse for serology. There are many medical policies that reference the fact that the use of serology results in unnecessary utilization of antibiotics. And, they also cite the society guidelines for what the appropriate testing modalities are. So for that reason, serology has become, harder to get reimbursement for, just because the medical justification for it has been challenged, and it's not a guideline endorsed modality. So I do face challenges from that, but the urea breath test and the stool antigen test tend to be reimbursed about the same, in the sense the likelihood of rejection or denial tends to be equally low for both.
Okay. A couple questions about transmission. One attendee asks, is stool testing recommended for immediate family of those who've tested positive?
It's not recommended, but it should be, because as previously mentioned, crowding, sharing of utensils, things of that nature, which really are common among close family members, can result in transmission. And there are instances, both anecdotally that I've seen and documented in the literature, where patients are treated, eradication is confirmed, and then they get reinfected. And this can happen repeatedly. And the culprit is that there's a household contact through whom they're getting reinfected repeatedly. So it certainly makes good sense to do that. But the guidelines don't specifically, they don't specifically make that recommendation.
And is that, that reinfection process, is that, you mentioned, fecal oral is kind of how this usually happens, but is it also just straight up oral transmission possible?
Yeah, there are two modalities. Fecal oral is the most common, but it is also transmitted from an oral to oral route. Okay. And among household contacts, that may be the one that predominates.
What about the possibility of screening programs in, key populations where we know the prevalence is really high, not in the context of people presenting with symptoms, but just, in the population at large? We have one question asker who raised the question of Alaska, where, the rate is, upwards of 75%. And they say that, there may be concerns regarding antibiotic stewardship, with reinfection. How has the field thought about the possibility of that kind of broader screening?
That's an excellent question. Globally, screening has been tested in various parts of the world where H. pylori prevalence is very high. Most notably in China, there are areas of China where the prevalence can range from 50 to 70%. And there have been trials where asymptomatic individuals, were tested for H. pylori and treatment was offered. And what they did notice in those scenarios was that the rates of gastric cancer did decline. Now, what was found is that there is a kind of a continuum of findings in the gastric lining related to H. pylori infection. Almost everyone who gets H. pylori gets atrophic or gets chronic gastritis. that can progress to intestinal metaplasia. And when intestinal metaplasia is present, that's a pre-malignant change. What we see is that for individuals who have more advanced changes at uh, at the tissue level, if they have intestinal metaplasia, then eradicating H. pylori infection may not markedly reduce their risk of gastric cancer. So there may be a point of no return, and for individuals who are at that point, eradication of H. pylori may not make a difference. But short of that stage, it does make a difference in the long-term risk of gastric cancer. So in high prevalence areas, it absolutely makes sense to have screening programs uh, for H. pylori. Now, in the United States, most of the policy is made looking at the whole population. If you look at the whole population, the prevalence is, 30%, 20%. The prospect of population-based screening becomes more problematic. And if you look at gastric cancer in the United States, as opposed to in China, in South Korea, and elsewhere, our overall rates of gastric cancer are quite low compared to those other societies. So you're essentially going to have to screen a lot of people, and the cancer that you're screening for is not a very common cancer. So the cost efficiency is very different in the United States across a population as opposed to in China, in South Korea, and elsewhere. So for that reason, broad screening has not been seriously considered in the United States. The point you bring up is a good one, because there are pockets within the population where the risk is very high. And I certainly think that it is important to target those populations. I'm not aware of any screening programs, and certainly no guidelines that exist right now targeting those specific populations, but it certainly would make good public health sense.
Yeah, I mean, I imagine you would have to, be able to really show that the intervention, the screening, leads to improved gastric cancer outcomes. But on a smaller population basis, that might be easier than on a whole population basis.
Yeah, and I think if we can extrapolate the results from the study in China, where it did help reduce the overall risk, I think if we accept those findings, then that may provide justification to doing that in the high-risk populations here.
We have a lot of questions about molecular tests, which is appropriate for me because I write primarily for GenomeWeb, although I write for 360DX2. So what's the state of the field in terms of PCR or other molecular tests for this bacteria?
As first testing, it's much more expensive than the modalities that are available. So it's primarily a cost issue. With breath testing, you can't really do PCR, obviously, but with stool specimens, you can. With histologic specimens, you can. The context in which PCR is being utilized is in resistance testing, where you make the initial diagnosis by a different modality because it's much cheaper to do that. And the majority of the tests will be negative. So you use the cheap modality to separate the positive, people who are infected from those who are not. Once you've identified the people who are infected, you can then test them for resistance to common antibiotics. Clarithromycin is, it's one of the most commonly used agents for the treatment of H. pylori. Clarithromycin resistance is very high in many communities. We have molecular ways of detecting resistance to clarithromycin and to some of the other antibiotics that are commonly used. So the role that PCR-based testing may play is really to then, once we identify the positive cases, to further characterize what type of strain is this? Is it resistant to X, Y, and Z antibiotics, and kind of provide guidance for which regimen to utilize. So that's kind of the area where it is promising. They've tried to look at PCR-based testing of saliva, but the accuracy did not rise to the level of the non-PCR based test that we spoke about.
What about blood-based testing, blood-based antigen tests? Is that something that's been explored?
I'm not aware of anything that reached levels of accuracy that led to serious consideration.
Okay, makes sense. And I
I mean,
guess, oh, go ahead.
and also the main thing is that the infection tends to be a gut-based infection. It tends not to be as much of a systemic infection in the sense that uh, you don't have free passage of H. pylori bacteria into the bloodstream. So in that sense, the blood-based tests, if they're not antibody-based, may not be as accurate.
Okay. So just as a final question to wrap things up, do you have any thoughts on how else this area of care might be improved or optimized in the future?
I think the sort of big focus of diagnostics and of therapeutics is personalized medicine. And I think, as learned in this talk, a lot of stuff around H. pylori is based on population medicine. There are certain subpopulations that may require screening or more aggressive testing, but we have guidelines that are based on very broad, broad population-based approaches. So I think the future is really to look at individual risks and, to essentially calibrate H. pylori testing towards that, to essentially target specific populations that are higher risk for infection, higher risk for gastric cancer. And then when we do perform testing, to essentially maybe perform testing for antibiotic resistance so that we know how best to treat these individuals to optimize successful eradication. One of the areas that has been looked at is to look at virulence factors, because there are certain cases, certain types of infection that are more likely to lead to gastric cancer than others. And this has to do with the specific virulence factors that might be present. So again, if we were to identify individuals with the high-risk virulence factors, is there any rationale to screening them more aggressively for subsequent development of gastric cancer? So I think all of those are areas where, there is promise that we can refine treatment and we can offer the right level of treatment to the right individuals.
Great. All right, that's all the time that we have for today. We'd like to thank Dr. Ali and our sponsor, Meridian Bioscience. If we didn't have time to get to your question, we will do our best to follow up with our experts. And as a reminder, please look out for the survey after you log out to provide your feedback. If you missed any part of this webinar or would like to listen to it again, an archived version will be emailed to all attendees. Thanks so much for joining us.